In the fourth section, we will talk about another condition, which is the intracranial epidural abscess. So far, we talked in detail about the subdural empyema or abscess. Now it's the epidural abscess. We will talk about the etiology and pathophysiology of epidural abscess, how the patient present, what are the clinical presentations and diagnosis of epidural abscess, and also the treatment and prognosis of epidural abscess. So intracranial epidural abscess, a suppurative infection occurring in potential space between the inner skull table and the dura. So epidural, between the skull and the dura. So this is the epidural abscess between the meninges are pia mater, arachnoid matter, dura matter, and then dura matter is attached to the cranium or the skull bone. So epidural, subdural, we said the formation of abscess between the dura matter and arachnoid matter, but in this case it's between the skull bone and the dura matter, and as a result you can see there is also the damaging to the skull bone that can occur. So suppurative infection, the difference is subdural was between the dura and arachnoid. Now this is between the skull table and the dura, inner skull table and the dura mater, epidural abscess. The etiology and pathophysiology of epidural abscess, less common than brain abscess or subdural empyema. So epidural abscess is less common than these two conditions. Less than 2% of focal suppurative central nervous infection. Develop as a complication of craniotomy. So if the procedure is performed like craniotomy, we said subdural empyemas are drained by the craniotomy. So and when the craniotomy or opening of the skull bone or cranium is done for any other reason, usually there is chance of infection that can cause epidural abscess. So craniotomy. Compound skull fracture, again very common cause. Spread of infection from frontal sinus, middle ear, mastoid and orbit. Develop contiguous to an area of osteomyelitis. So in the area of osteomyelitis, it can affect and cause epidural abscess. The potential rather than actual compartment. It is in the potential rather than the actual compartment the epidural abscess is formed. Infection dissect the dura mater, it dissects away from skull table as it spread. So it's the infection between the skull table and the dura mater. Dura mater is attached to the skull bone. So when the abscess is formed in between the skull table and the dura mater, naturally it will separate the dura mater from the skull. Other small, often smaller than subdural empyema, rarely result from hematogenous spread of infection from extracranial primary site. So it spread from the extracranial primary site, and usually it can spread through the blood route or its hematogenous spread of infection. Bacteriology, or what are different microorganisms that can cause epidural abscess, is the same as the subdural abscess. Organisms like streptococci or anaerobic organisms, staphylococci or gram-negative organism. Usual cause develop as complication of craniotomy or compound scalp fracture. So very two common predisposing conditions is the procedure like craniotomy or any roadside accident, fall, injury to the skull bone, which is a compound fracture, can cause epidural abscess. Clinical presentations of the patient, we have fever, same as subdural empyema. 60% of the patient will have fever. Headache, 40%. Knuckle rigidity, 35%, seizures, 10%, focal deficit, 5%. So focal neurological deficit are more common with subdural empyema as compared to epidural empyema. But there is headache, there is fever, there is seizures, knuckle rigidity associated with epidural empyema. Then we have development of symptoms is usually insidious, it's slow in onset, not sudden. Periorbital, around the eyes, edema, spots, puffy tumor. Associated frontal bone osteomyelitis present in 40% of the cases. Diagnosis is considered when the headache, fever, and there is recent head trauma present. Usually it can be, it should raise the suspicion that it might be epidural abscess, because it is common with the surgical procedures like craniotomy and compound head fractures. There is the periorbital swelling because it is between the skull bone and the dura mater. When it's spread, it can cause the swelling and it can cause spots, puffy tumor. Occur in setting of frontal sinusitis and mastoiditis. In the setting of otitis media. So these are some conditions that can be considered when there is epidural empyema. Then if there is a recent neurosurgical procedure, then we should also suspect that the patient might have epidural abscess formation. Wound infection invariably present if there is recent neurosurgical procedure performed. Other symptoms are subtle, altered mental status in 45% of the cases, fever and headache. So there is infection of the wound after the neurosurgical procedure. There is also headache, fever, and altered level of consciousness or altered mental status. The diagnosis is by the sensitivity of computerized tomography limited by the signal artifacts present arising from bone of inner skull table. So artifacts, here you can see the artifacts present that can interfere with the diagnosis. CT appearance is the lens. You can see its appearance like a lens or crescent shape, hypodense, extra-axial lesion. Cranial MRI with the gadolinium enhancement can also be used. On MRI, what are the findings? It appears as lentiform or crescent-shaped fluid collection. Hyper-intense compared to cerebrospinal fluid on T2 weighted image. So these are some findings which are present on MRI. On T1 weighted images, there is collection of fluid which is iso-intense. Collection can be hypo-intense compared to brain, and there is linear enhancement on gadolinium administration. So these are the findings on MRI and T1 weighted images. The treatment is immediate neurosurgical drainage as with subdural empyema, empirical antimicrobial therapy, combination of third generation cephalosporin, vancomycin and metronidazole. So treatment you can see is the same as subdural empyema. The factors that can contribute to the formation of epidural empyema are different. Mostly it's due to the neurosurgical procedures or compound fractures associated with head trauma or injury. Antibiotics continued again for 3 to 6 weeks after the drainage. Additional therapy in those with associated osteomyelitis. Prognosis of the patient is in modern series, mortality rate is less than 5%. In most survivors, for full recovery is the rule. So prognosis is good, full recovery is present in patients who are treated well. So that was all about section 4. Thank you for watching sqadia.com.